Hi everyone, my name is Teodora Lalova-Spinks. I'm a postdoctoral researcher at Ghent University, and it's a huge pleasure to welcome you today in the company of an esteemed and quite stellar interdisciplinary and international panel of speakers joining from Belgium, Toulouse, Vienna. We're here today to discuss citizen involvements in health technology developments and the role of ethical principles-based frameworks. And it is a topic that I believe all of us in our professional life, as researchers, as patients, as citizens, we have been bumping into. We have been seeing definitely the more and more the increase and the promises made by digital devices, by digital tools, AI, when it comes to healthcare delivery, when it comes to biomedical research. We have also seen in the last couple of years at the level of the EU policy and new legislative developments, new regulations, the emphasis that is made on making promises to make more data available, to produce and to train such devices, personal data available, and also the promise to empower citizens and to empower patients when it comes to control over their data and to capture their voice in the development and the design of new tools. I realize I'm a little bit early, but this is all going to be recorded. So we're going to upload the recording later on the Mathematica YouTube channel. And everyone that registered and also in your networks, you're going to have a copy of the discussions and the presentations. When it comes to the topic, I'm very happy to welcome 5 very interesting, very knowledgeable, insightful speakers with us today. And I'm also very happy to share that this event is proudly supported by 3 initiatives at Ghent University. First, Mathematica. It is a research platform dedicated to interdisciplinary academic research and integrated education when it comes to health policy, health privacy law, and medical ethics. Its steering members are Professor Tom Goffin, Professor Grit Verheneman, and Professor Hedy Mertes. And we have today with us Tom Goffin and Grit Verheneman. So at some moments in the discussion, it would be great also to perhaps hear from them. We also have the support of the Ghent Health Academy for Lifelong Learning. Perhaps many of you in the audience discovered, thanks to their websites, the possibility to join today. They organize programs, courses, additional training for healthcare professionals and other interested third parties. And the website, the webinar is also part of the activities of the Capri cluster at the Department of Public Care and Primary Care at the University of Ghent, of which I'm also a member. Capri stands for Caring Principles for Health Innovation. We're also quite interdisciplinary group of different experts spanning data science, ethics, law, primary care, and so on. And it is supported by the King Baudouin Foundation. A couple of words about the flow of the webinar today before I give the floor to the speakers. Each of our speakers is going to have 10 minutes to introduce their main pitch, main topics, main ideas on the topic. After which, at the end of all the presentations, we will have plenty of time to discuss together. So if any questions already come up on your sides from the audience during the presentations, don't hesitate to put them in the Q&A box, and I'll make sure that we take them upon during the discussion at the end. With that, let's dive in. I'm quite excited to welcome the first speaker for today, Professor Tom Braekeleirs from Ghent University. He has over 25 years of experience in the IT industry. In 2023, he became visiting professor of digital medical technology here at Ghent, focusing specifically on AI and healthcare. He is an advisor, podcaster, speaker, and columnist on all things digital in health. And in 2022, he received the Prof Awards for innovation for his contribution to advancing digital innovation in healthcare. It's great to have you, Tom. I leave the floor to you.
Well, thank you, Theodora, for that really great introduction. So It was already said, I'm a visiting professor at the Faculty of Medicine and Health Sciences, and I focus there on the impact of digital technology, specifically in health, and so commonly known under the name of health tech. But before we jump into the deep dive, I thought maybe it was a good idea to give a bit of perspective from my end on what health tech is, or what the role of health tech could be, what kind of technologies do we define under that umbrella? And then more specifically, I want to share a very high level of framework we've been using in the faculty on AI specifically, on how you can make it acceptable. So that's kind of my area and my introduction for the rest of this webinar. So when we jump into the technology side of things, there's actually two sides you can look at it. One is you can look at it from a very technological point of view. What is going on exactly in technology? If you look, for instance, at the domain of AI, which is extremely rapidly evolving in healthcare, it's really easy to get sidetracked on all the different technologies. What I like to do is to focus on the human stack. And also in this webinar, it's about citizen involvement. At what point does somebody become a patient, for instance? Is it a citizen or a patient? Do you need to be in the healthcare system to be considered a patient? That's maybe a philosophical thing, but I want to extend that thinking also on the domain of health tech. That's why I'm focused on what do we need to do in terms of AI, for instance, in order to get human acceptance of a digital technology. So for the rest of the presentation, I'm not going to focus too much on the tech stack. I will focus on the human stack. Now, the reason why we have so much focus on digital health these days is because, don't need to convince you of that, we are living in a perfect storm in healthcare. We are going towards a situation in which we really have to profoundly ask ourselves questions around affordability of healthcare as a whole. And that has several reasons. One of the reasons we've been knowing for quite a few years is the change in demographics. We have the pyramid, the population pyramid, that's kind of evolving, flipping upside down. We have, due to the advancement of science, we have been able to cure certain diseases. We have been able to convert diseases that used to be lethal into chronic diseases, which cause the average age of people to go up. And when people live longer, we have more lifestyle diseases, diabetes type 2, neurodegenerative diseases, and what have you. So that change in demography, not only purely from a point of view of we live longer and we have fewer kids, also caused a sort of financial crisis where we need to invest dramatically to maintain the same level of care in a given country. But at the same time, the budgets are being stretched left and right. So we need to look at more effective use of the budget. I'm more specifically using the term effective use and not per se efficient use, because efficiency is kind of an internal exercise. Effectiveness is an external exercise when we think about the patient. And then thirdly, in that flow of big waves coming in healthcare, we have been going through multi-crisis moments. We've had COVID 5 years ago, which caused a lot of strain on the system in multiple countries. It didn't crack in every single country, but in many countries, it was a huge burden. And that was followed by another crisis, the energy crisis, and an inflation crisis economically. And now we have a geopolitical crisis being caused by new forces in the world that are taking positions. So that all has an impact on the way we deliver care, the way we look at things, the way we look at budgets, and what have you. So this is kind of a culmination in which we are currently living. We can debate about it for a long time, but that's the reality. The question I like to ask is, what can digital technology do to help in that perspective? And for me, a couple of years ago, it kind of culminated in one sentence. And this is, for me, the kind of the baseline if you think about healthcare technology. Why do we actually need technology? Well, first and foremost, it's about patient empowerment. How can we help the patient in the most effective way? How can we give part of the power that used to be at the other side in the care delivery system? How can we give that power back to the patient? How can we tap into the whole revolution of quantified self, where people want to take control of their data, of their healthcare, of their outcomes, and what have you? It's not only about patient experience and patient empowerment, it's also about the care professional. And that's often forgotten. We think about patient empowerment and we put in place digital tools to help that specific patient in a very good way. But on the flip side of the medal, we forgot that there's a care professional that also needs to interact with the technology. And when you think about technology, it should be the right technology, not just any technology for sake of. It's about having the right technology at your disposal. So just for the sake of technology, installing a VR headset on a patient's head is not per se always going to help that patient. It may be a cool tech demo, but it's not really helping the patient in every scenario. And here's another problem. Technology is way too visible today. If I talk to people working in a healthcare organization and I talk about digital technology, often I get a three-letter word as sort of a response to the question, what is digital for you? It's a three-letter word, COW, computer on wheels. It's a laptop that we have to use. There's lots of have to in that sentence usually. So technology is way too visible. So we need also, from the industry point of view, need to put in a lot more effort to make the technology a lot more accessible, a lot more simple to use, and even make it invisible. It should really disappear into the walls. But at the moment you need it, it should be present. And that's for me kind of the essence of the role that digital healthcare technology can play. So if you look at digital technology as a whole, there's of course several topics we can talk about. For me, it kind of comes down to a couple of big building blocks that will become important or are already important today, but that may become more important in the future. At one end of the spectrum, you have connectivity. That's everything that has to do with 5G, for instance, or 6G already in some countries. And at the other end of the spectrum, you have the end user, the patient, the care professional, whoever the end user is. The way in which we interact with current technology is not natural. The way that we need to type on a keyboard, for instance, is not natural. Voice is natural. Looking at things is natural. Gestures are natural. The whole arrival of AI and the large language models is kind of under the radar, creating a new revolution on the interface front as well. We are evolving from the graphical user interface, which we have known since the 80s, since the arrival of Mac OS and Windows 1.0. That was a graphical user interface. We've been living in that GUI timeframe up until now, when there's all of a sudden a language user interface arising, one that actually makes sense. So that's also the impact that AI is having on that front. Underneath is robotization. And when I mean robotization, I don't mean always per se the physical robot. It could also be a chat function. For instance, the chat in ChatGPT is actually the bot behind it. The real intelligence is underneath that. So AI is playing a crucial role today as well. How does AI get so smart? It's based on lots of data, and that data often come from sensors. And sometimes these sensors are physical measurement devices. Sometimes these sensors could be us human beings observing something, putting it into a system, and as such generating data that is then being fed into AI. Underneath all of that, you have the compute power, which is called cloud computing. Also on a geopolitical front, a very interesting discussion to observe. But anyway, there's ways you can bring that cloud closer to the edge, closer to the data, which is then called edge computing. For me, this is kind of the overall picture when we think about health technology or digital technology in healthcare. AI is front and center today. That's of course very obvious. It's not an easy industry to implement AI in, and that's why I've been working on acceptable AI sort of as a framework. Now, really roughly what do I mean with acceptable AI? It's basically 7 questions that you can ask, or 7 dimensions that you need to dive into, and you need a positive reply on all 7 of them. It's desirability, it's about feasibility, it's about viability, ethical, legal, causal, and explainable. Now we'll be discussing the ethical and the legal part, of course, but that's 2 of the 7 dimensions, which are extremely important. But for instance, it starts at desirability. What does a patient actually want from a technology? What does a care professional actually want? And are they able to articulate what they want? So that's why I think that this topic of today is extremely important, because we also need to educate patients about digital technology in healthcare so that they are able to better articulate what kind of solutions they actually want. So this is a framework in the world of AI. I won't take up too much time, but these 7 dimensions are not only valid in AI. Of course, when you look at causality and explainability, those are typical AI examples, but it's more of a framework that can be used for health technology all up. One of the biggest struggles we're currently having is bias. The healthcare inequality that we currently already have in healthcare is being put on steroids. And the reason why it's being put on steroids is that because we are currently digitizing everything we know in healthcare, we are also digitizing that bias. And when you apply AI on top of things, it becomes exponentially bigger. So the health inequality that we currently have is going to get bigger with AI. That's a real concern that I have and that many people share. About health inequalities and the impact that AI can have. We need to be very cautious about it, because what AI is doing, it's showing us a mirror as society. What can we do as a society to make sure we don't allow for these health inequalities to get bigger? So AI is providing us that mirror, but I think for me, this is the sort of the leitmotif on where we should look at healthcare technology. It's about patient and care professional empowerment. It should be the right technology. It should be as invisible as possible, but as present as needed. That being said, I'm going to hand it over to you, Teodora, for the next speaker. But this was just of my brief overview on health technology.
Teodora,
you're muted, Teodora.
Thank you. Thank you for saying. Thank you very much, Tom, for the very insightful pitch. And I look forward to the questions we're going to have with you at the end of the discussions. I'm now bringing to the screen Gauthier Chassang, who is joining us from France, from Toulouse. And he's going to bring the perspective of the legal experts, of the lawyers. Gauthier is a legal expert specialized in European law, scientific research ethics, AI governance, and data protection. Since 2010, he has worked at the French National Institute of Health and Medical Research. Based at the Toulouse Faculty of Medicine, he collaborates on national and European research projects in the field of health technologies. He's also involved with the Research Data Alliance, contributing to discussions on AI and data governance at international level. Looking forward to your talk, Gauthier.
Thank you very much, Teodora, and thank you for the invitation to this very interesting webinar. So in this talk, I will briefly present some elements illustrating the European approach for involving citizens in the governance of AI innovations in health. So Europe is well known for its ability to regulate and even for over-regulating innovation. Nevertheless, by reconstructing the normative puzzle, we see that the entire ethical legal framework concerning AI and its applications, including in health, is made of interrelated soft law and hard law instruments that promote inclusive AI governance and citizens' involvement at several levels. The entire normative structure not only aims to offer opposable landmarks for developers, deployers, and users, but overall to inspire best practices from operators in a spirit of collaboration and responsibility for building trust in digital health and AI systems. In essence, Europe adopts a humanist approach to digital health and AI technologies and develops a principle-based ethical approach where people are at the center of innovation, meaning that AI systems must be at the service of human beings and ultimately aim at increasing its well-being. Ethical issues should be addressed from the design of the AI system, and solutions should last for the entire life cycle of the system, what require a proactive behavior from developers and policymakers to address key challenges to promote democracy, EU values and human rights and meet the sustainable development goals. However, from principles to practice, there are still challenges regarding the concepts underlined by the ethics principles, regarding their operationalization in real-world contexts that can be more or less constrained, and we are still in an ongoing translational learning process. But we are at the beginning, and we will see in more details how ethical guidelines and legal frameworks promote citizens' involvement in AI policy and practices. In this talk, I will use the term citizens in its broad acceptions, aiming population at large with its heterogeneity, including individuals, group of individuals, and representative organizations. This includes various categories of persons, educated and lay persons, professionals, groups that are concerned by the development of AI or by its use, and varied subgroups depending on age, culture, pathology, etc. I will use the term AI system to refer to software employing machine learning techniques to formulate recommendations or to make decisions that will impact the virtual or physical environment and influence the traditional decision-making processes in health. For recreational or medical purposes, this covering expert AI systems such as diagnostic tools for a specific disease, for example, but also generative AI systems that can be used as decision-making support tools for health or medical purposes. In the same way, the terms involvement in AI governance designate a contribution to the debates, to the works or activities related to AI framing or use that shapes or implement AI policies. It can be a direct, individual, or indirect and collective involvement. Citizens' involvement can be implemented at several levels in the context of broad or specific initiatives on AI governance. And in the talk, I will particularly address the elements pertaining to the broader and to the most focused contexts. So first, let's tackle some examples of citizens' involvement in the broader context, namely in the normative process on AI, starting with their involvement in the production process of the European ethical guidelines, with the example of the elaboration of the ethics guidelines for trustworthy AI. During the drafting of this text, the European Commission created the AI Alliance as a multi-stakeholder forum enabling an open dialogue on AI, to contribute to the work of the high-level expert group and to facilitate exchanges of knowledge, viewpoints, best practices, and to foster collaboration in implementing the guidelines with the Altai tool that is helping for self-assessment of the AI solutions. It is both a gateway of resources and a multidisciplinary community of exchange dedicated to constructive debate on all societal implications of AI and related normative actions. And the ethics guidelines, as well as the European Commission proposal for an AI Act, were shaped in the discussions generated by the Alliance, and therefore is resulting from a mix of expert and community-driven feedbacks. The Alliance is still active today, and you can join, of course, if you want. The European Commission also performed an open public consultation in the design of the white paper on artificial intelligence in 2020 to collect views and opinions on the proposed strategy, which already mentioned that AI governance structure should guarantee maximum stakeholders' participation. Many contributions were submitted and analyzed by the Commission, and some health professionals and patient organizations contributed, such as the European Patient Forum, the Commission published a summary outcome and the individual responses on its website for ensuring transparency. The results contributed to the preparation of the various regulatory options at EU level. A large number of stakeholders were supportive of an EU regulatory intervention to address the challenges and concerns raised by AI in general, with a risk-based, technologically neutral and proportional approach. Most of the stakeholders requested for a narrow definition of AI and sectorial definitions of risk categories, while calling the Commission to avoid duplication, conflicting obligations, and over-regulation. And the majority of the feedback received have been translated into the AI Act, in particular regarding the definition of risks to be understood as potential reasonably predictable risks of harm to health, safety, or fundamental rights of individuals, and regarding the sectorial risk-based classification of AI systems to which are attached legal requirements. As you can see, medical devices are classified as high-risk AI systems, subject to specific obligations for the providers and deployers, such as the mandatory CE marking and the setting up of appropriate risk and data governance measures. Moreover, the AI Act institutionalizes citizens' participation in the regulatory processes through the creation of the European AI Board and overall the Advisory Forum, both acting close to the European Commission on specific issues raised by the technological advances in the field. Public consultations continue being regularly implemented, and there is one that is still available for feedback until July on the topic of the use of data to develop artificial intelligence. So in this context, it is important to underline the role of patients' representative organizations like the European Patient Forum that I mentioned, but there are others, of course, because they have both advocacy and educational objectives for their members. They enhance connections between individuals, their intermediary representatives, and the public policymakers. They collect and convey patients' views on AI technologies while developing AI literacy through various actions, events, and resources such as the EPF AI Knowledge Hubs that I mentioned here more specifically. Besides these pipelines for contributions, there are also many initiatives for involving citizens more directly within the process of development, deployment, and use of AI. From research projects to operational governance of the systems. And here the EU promotes a co-design approach to implement in research projects on AI system. First, the research responsible should identify relevant stakeholders to involve, to design a protocol with objectives for their involvement, and to plan resources to implement this strategy at each stage of the AI development. Involvement in the project activities can be more or less integrated, but usually it facilitates the ethics assessment as citizens bring unique contextual knowledge and practical experiences to consider. The EU guidelines on trustworthy AI can be used to drive the contribution with regard to its 7 requirements, and in particular regarding human agency and oversight, transparency, privacy and data governance, and diversity, non-discrimination, and fairness. But of course, all of the principles are intertwined and echo each other in practice. So let's quickly go deeper regarding these 4 principles. Regarding human agency and oversight, the ethical guidelines require that the system protects user autonomy, is accompanied by measures and policies ensuring appropriate monitoring of the machine learning processes and uses in real world, and that it preserves or even enhances the respect of human dignity. Each requirement is developed in more details and offer options of design to consider according to the intended use of the AI system and its characteristics. Here, citizen involvement can notably contribute to the identification and selection of human oversight measures to prevent and minimize risks and how they have to be implemented and tested, to the design and functionalities of human-machine interfaces according to end users' needs, to the design of mechanisms allowing to report, assess, and communicate complaints, ethical concerns, or adverse events, and to the discussions on potential ethical tensions or dilemmas and potential trade-off that will need to be taken and documented. We have examples of inclusive oversight governance in practice that have been tested in healthcare AI-based medical devices, notably in France, with the Collège de Garantie Humaine, which are collegial body that bring together professionals, citizens, and innovators. The idea being to apply the principles of AI regulation upstream and downstream of the algorithm itself by establishing critical points of human supervision. The body performs retrospective review of cases to provide a human perspective on the options recommended or taken by the algorithm to ensure that the algorithmic process remains within the bounds of effective and ethically responsible machine learning development. The files to be audited could be defined on the basis of predetermined criteria, such as when adverse events have been observed, or on the basis of a random selection. The overall objective is to avoid mechanisms that fully delegate critical health decisions to digital and algorithmic tools. Regarding transparency, it is important to respect the patient's right to know about the use of such system, its rationale, and potential incidental findings of clinical relevance, to strive to make the system operations explainable, and explainability is particularly relevant in health due to the important risks that the decision made or based on the AI system output can generate with regard to the individual or collective rights and interests, the idea being to avoid black boxes in this domain, and to work on the intelligibility of the results for the user and instructions of use. Here, citizens could usefully contribute to the quality of communication documents, pipelines, and interfaces for user, the methods used to explain the decisions made by the AI system and the outputs, and with regard to the existence of a feedback loop for surveying if the users understand the decisions of the AI system. Regarding privacy and data governance, guidelines require to ensure personal data protection in compliance with the EU General Data Protection Regulation and national health law and standards, to plan protective technical and organizational measures, and to implement data subjects' rights throughout the AI system life cycle. Here, the citizen can usefully contribute to the identification of potential roadblocks and levers regarding data processing and sharing in AI training, the strategy on data quality, integrity, confidentiality, and accuracy, to the establishment of adequate privacy policy in compliance with the GDPR and national laws, and to the definition of the parameters, functionalities, and support services to consider for allowing efficient enforcement of data protection rights. Regarding the principle of diversity, non-discrimination, and fairness that is closely attached to the preceding, it is important to take measures to avoid harmful algorithmic bias, to develop universal design, and to ensure fair societal impacts of the solution. Citizens can bring their expertise to the strategy to maximize inclusivity, appropriate uses and uptake of the AI system, to the assessment of methodologies employed to meet the requirements. They can also contribute to the testing where it is relevant, and to discussions again on design choices and potential ethical tensions and trade-off found. As a complement, the building of the EU data infrastructure, such as the European Health Data Space, offers new opportunities for implementing participatory governance to enhance data subjects' controls over the reuses of their personal health data, including for AI research and technological development. The recent regulation about the European health data space fixes obligations for the national health data access bodies to ensure transparent data uses, to plan mechanisms to respect the individual right to refuse the secondary uses of health data, as well as their right to know about relevant health information that can be susceptible of preventive, diagnostic, or treatment actions. In addition, the data altruism schemes by which individuals consent to broad uses of their data for authorized purposes through data altruism organizations will be integrated in the data space, and this one and data in the data space, sorry, will benefit from a stakeholder forum composed of representatives of patients, consumer organizations, health professionals, industry, scientific researchers, and academia that will express societal views to advise policymakers and ensure effective implementation of the regulation. Finally, citizens' involvement in the framing of AI innovation can be exercised through judicial procedures and case laws. The EU law offering several legal bases for individual and collective claims and ensuring privacy protection and quality of AI-based products and services. In this regard, the new EU directive on product liability eases the burden of proof for the plaintiff acting against an AI-based device by establishing a presumption of defectiveness and of a causal link between the damage and the product functioning if proof is excessively difficult to provide due to the technical or scientific complexity of the product, and if a product defect and or causality is at least probable. This enhances the global actionability of citizens' rights and could be particularly important for innovative medical devices. So to conclude, the EU ethical principles and legal acts and related implementation tools ensure democratic processes in AI governance and promote the design of appropriate practices for citizen participation throughout the value chain and life cycle of the systems. Citizen participation is implemented through various means with various intensity. Partnerships with AI developers and researchers bring the perspective of professionals, but also patients and lay people, which can contribute to creating more user-friendly and equitable AI system in the public interest. Other initiatives can also be developed, such as citizen science projects that can provide valuable information and data from the grassroots level. But one of the key challenges to successful participation in the development and use of AI is to improve knowledge of AI, as it has been said previously, among healthcare professionals and with the global population. I thank you very much.
Thank you very much, Gauthier, for a very interesting and very comprehensive. I know in the limited time we have view of the legal and ethical toolbox and all the different examples. Look very much forward also to questions and to discussions. Something to the audience, please don't hesitate to put any questions you have to Tom, to Gauthier, to our other speakers in the Q&A. It will be discussed later on. So we're now moving to our last two speakers. Stefan Gijssels, who will be presenting the patient perspective on the topics we're discussing first, and then we're going to finish with the innovator and tech developer perspective. First, Stefan, he's the chair of the Patient Expert Center, PEC. It is an organization that trains members of patient organizations to become patient experts in their disease area, which, as we saw from the previous presentations, education is very, very much important. He's also a member of the boards of Alzheimer League of London and advisory member of Prolong, the Lung Cancer Association, as well as the co-founder of Digestive Cancers Europe. This year, he published the book De Stem van de Patiënt, The Voice of the Patients. I'm also very curious, Stefan, if we're going to also see perhaps an English edition. So far, it's only available, as much as I know, in Dutch. Thank you, and we look forward.
Thank you, Teodora. Hi, everyone. So as Teodora said, my name is Stefan. I'm chair of the Patient Expert Center, We're an organization that is created by patient organizations to educate patients to become patient experts. So you can see on the slide here many different organizations, different types of cancer, diabetes, multiple sclerosis, endometriosis, Crohn's and colitis, rheumatology, cardiological diseases, and rare diseases. So many diseases that we represent, and we train patients to become patient experts. Afterwards, they can actually help other patients to manage and cope with their disease, but also to represent their association with more knowledge in professional working groups with hospitals, industry, and research groups or government agencies. So far we have 264 patient experts that we trained, so it's a little bit higher than the number on the slide here. And we have 160 in training at this year. So it's already quite a number of patient experts that we can offer to all the different professional partners to work with. What we've done at the same time is designed a number of services to integrate the voice of the patient in a more formal and structural way in a number of services that create value for our partners. So in patient information and education, how many patients should we involve? What's the process behind it? What's the difference between individual naive patients in focus group sessions, or the role of the patient expert to guide and supervise the whole approach. Patient pathway design is very broad. It's maybe inventory of everything the patient needs to be able to cope with the disease. Designing clinical research, quality of care in the hospital, designing care pathways in the hospital, policy plans for disease, research prioritization, etc. All that is available on our website in Dutch and in French, but with the materials also available in English, and that's open source. Together with this, we designed a number of tools so that we can integrate this in a professional manner and to obtain the results of this interaction between patient organizations and professional partners in a really solid and robust way. Why do we do that? First of all, because it's a democratic right. I think it's all about us, and like human rights organizations, we have this slogan, no decision about us without us, which is unfortunately still too common today. But also because it generates value. I mean, it's one of the few industries, healthcare, where the role of the customer, the end user, is very absent compared to more commercial activities in fast-moving consumer goods, for instance. So we know more about living with the disease than any specialist in any hospital. So it's very important to bring these together. I mean, any drug, any technology that comes with patient insights to the market will have better value for the company bringing it to the market. Same thing with the organization of care in hospitals and with organization of care at policy level. The model we designed is that the patient perspective and the medical perspective are equally important, both at individual and collective level. And if we are very familiar with the quadrant on the top left, diagnosis, treatment, supportive care, and follow-up, which is very technology driven, but also, of course, the human aspect of the medical staff attending to the patient. But this will only be optimal once it matches the life goals and life expectations of the individual patient, when it matches the context of the patient in social, financial, professional way, when there is sufficient health literacy with the patient to understand what is expected from him, whether or not the patient has experience plays a role. Can the patient organize this practically at home? Can they deal with the paperwork, and do they find their way to all the services they are entitled to? Most patients do not have that opportunity. So the optimal care that we deliver will have suboptimal results for the simple reason that it's not integrated in the context of the patient. And it's not surprising that 50% of patients have low adherence to their treatment, with all the financial consequences for the sustainability of the healthcare system as a consequence. What we do as patient organizations is at the bottom right. So we are the collective voice of the patient. We support individuals to better understand what is needed to increase their adherence, to make sure it's integrated in their context, so that they understand what they're entitled to. And by doing that, we capture the collective intelligence and also data from patients. So we can identify needs, we can identify problems here, identified as medical vigilance, but we can also come with practical and creative solutions that a medical practitioner will not think about, but that is very relevant for the life and the quality of life of patients. And then we advocate to the health policy environment at the bottom left to make sure that everything is integrated in the way the healthcare system should work. The little bridge at the top is shared decision making. I'm not going to explain that. I hope you're all familiar with that. And then at the bottom, to have a plan for each disease looked upon and co-designed by a multi-stakeholder observatory. It's surprising that with all the money that is actually going on in healthcare, we don't have plans for every disease. It's shocking, but I think that's the reality. One of the leading principles for this webinar was the 8 caring principles, which are very important. But if you look at where we are, I made my personal monitor on my personal guesstimate, is that we are very, very low in terms of implementing this. So for most of the aspects in this caring principles, we are at the very, very beginning of what needs to be done. I think we're 2 or 3% of the way. It's not very integrated yet, the voice of the patient. So a lot of work needs to be done, especially at the governance level. What we sometimes hear is that the patient is at the center of healthcare. We can also say that patients are the alpha and the omega of healthcare. So actually, it's basic systems approach. It starts with patient needs and patient expectations. What do we want? What are what you want to do once you have a diagnosis or once you have symptoms? How does it work? And then at the end, it's patient outcomes. What is achieved by the system? And so everything that is happening, including AI, including data, is to a large extent in the organized care in the middle of the slide. And so this whole system should be oriented from listening to the needs and expectations of patients and to deliver outcomes in the end. The very bizarre thing is that we have no systematic data collection on patient needs and expectations, and we have no systematic data collection on patient outcomes. So there's thousands of billions going on in organized care. We don't know what is expected, and we don't know what the outcomes are. And I think this is something that really needs reflection in the way governments in healthcare is organized. We have a lot of data already, and most of the data that we have, I'm also in one of the working groups of the Belgian Health Data Agency. Most of the data that we have are in the organized care. We know exactly, the performances, the number of interventions, the number of surgeries, the number of diagnostics, the number of and the types of treatment. We have a lot of administrative data because that's where the money goes. That's where the payments are made. That's where hospitals are getting their finances from. That's where doctors get their fees from. And that's where nurses get their salaries from. So all it is very, very standardized, taken into account. We have huge amounts of data there. What we don't have information is actually what's happening to the patient in a collective level. We have no data by disease. We have no recent data by disease. We don't have any socioeconomic data on the patient, and we definitely have no subtle data on patient outcomes, on their satisfaction, on long-term consequences of the treatment, financial hardship, mental health problems as a consequence of their disease and their treatment. So the real issue is not which data, but it's also which questions. What is important for us? What is important for us citizens? And do we have the data to make sure that we can do what needs to be done? And the reality is that we don't have those data yet. So I think this is one of the top priorities that we need to take into account. And we as patient organizations can help set this up. So we can determine what the patients need by type of disease. We can identify what the key indicators should be, key performance indicators should be for patient outcomes, so that we can capture them and share the insights afterwards. And then in the process in the middle, we can of course help to support individual patients, but also to co-design patient pathways, as we're doing now, thanks to our patient experts, and also to co-design health policy plans for every disease. Because I think that's the granularity that you need to have traction and improvement in the way healthcare is organized. It's shocking. I mean, what I, you know, we talk a lot about innovation, but if all the patients in Europe with colorectal cancer were treated in the best hospital, so without any innovation, just use the best practice of the current best hospital in Europe, and all the patients would be treated in that hospital, 120,000 patients would not die every year. So that's a lot of patients just by better organization of care. It's nothing to do with new technology. Imagine the upside of that, what it would mean for society, what it would mean for the economy of the region if all these people were kept alive. That is unfortunately not the case today because we don't have data to understand what the patient flows are from A to Z. So we are some paradoxes to end. I mean, we are at the center of healthcare, but we are not involved in a systematic way in any decision making. Sometimes we're consulted, but that's like in the European Commission has these open consultations. I've been part of these open consultations with the European Beating Cancer Plan, with the European Commission Initiative on Colorectal Cancer and a few more, but we are not part of the decision making. In the end, it's all politics. They listen to us, and sometimes it's just a tick the box exercise. We have the legal right to choose in Belgium where to be treated, but we have no data or statistics on outcomes per treatment center. So what's the role of being able to choose where to be treated if you don't have any data on which hospital is the best or which doctor has the most experience? We're invited for stakeholder consultation, but almost at impossible times for people who are volunteers like ourselves and without any reward. I'm just showing one example of the Flemish public research grant system. So they're encouraging researchers to work with us, but they specify in their little print involvement fees for patient organization, including reasonable travel expenses, should be up to 250 euro per organization per year. So how far do you go with 250 euro per organization per year? That's a big question. That's the level of patient involvement in our research, unless we do everything for free, of course. Priorities that we advocate for are mostly ignored. And there's a lot of focus on technology because that's tangible, that's material. There's much less interest in how organization of care can be improved and how technology can be used in a real world practical environment. A lot of focus on therapeutic effect and much less on quality of life. I could go on and on, but I don't want to bore you to death. So to conclude, I think that it's boundary conditions are that it's great to involve patients. I think but it requires some equal footing, and that means that we are formally represented, not in the ad hoc workshops or ad hoc consultations, but that we have a formal role in the governance structure of decision making, that the patient organizations get a proper education and training. What we are doing now, we have to do it for free because nobody is willing to fund us. And we need the proper financing to be able to do that. I mean, we're the only part in the entire healthcare system that doesn't get any public funding. How is that justifiable? And then if you have a decision making, make sure it's granular, involve patients at all levels, so micro, meso, and macro level. Help us also and use us to prioritize the agenda, because very often we're involved at a much too late moment when the decisions are already made and we just say this works well or this does not work well, but it's too late to make significant changes. And make sure that we are integrated and part of every process that has impact on patients' life. That's our ultimate goal. Make sure that no decision is made about us without us from the very beginning and in a more robust and systematic way. Thank you. And my book can be ordered if you speak Dutch. The slides can be shared afterwards. Thanks.
Thank you very much, Stefan, for shining lights so much on such sensitive problems on the ground and how it is in practice and what are the paradoxes. Look forward very much to discuss this also during the Q&A. I'm now coming to our last speaker for the day, just before we can also open up the discussion to all of you on the floor. It's a pleasure to have Erik Laes from VITO representing the innovator, the developers. He is trained as an engineer and ethicist of technology and works at the Flemish Institute for Technological Research, VITO. At VITO, his field of expertise is in the governance of transitions, namely the politics of steering complex technological systems towards more sustainable futures. He is involved in the We Are Health project, which empowers citizens to take active control over their health data, which relates a lot with a lot of the discussions we had in the previous presentations as well, seeing an example from the practice. Thank you, Erik, and we look forward to your discussion.
Thank you, Teodora. Hi, my name is Erik Laes. I work for VITO, which is the Flemish Institution for Technological Research. We work mainly in clean tech development, but we also have a health tech department, and that's the department that I'm going to talk about today, namely about the We Are initiative. So we are not developing this initiative alone, as you can see at the bottom of this slide. We have been working together since 2019 with the Flemish patient platform, Domus Medica, which is the organization of the general practitioners in Flanders, and Zorgnet Icuro, which is the umbrella organization of the hospitals. So the advantages of going as the last speaker is, of course, that I can skip all the things that have already been said and more importantly, build on that. So what is the We Are platform? So it is a platform where we develop individual data pods for individual data citizens, for individual data owners, and so it allows them to get control over their health data. Most importantly, why are we developing this platform together with these other partners? Like the previous speaker said, I think we are seeing a transition from, let's say, to put it black and white, a system where the patient is mostly passive and the care system is oriented towards treating symptoms, so disease-oriented system. And we now see with all the health tech applications, the e-health, etc., that's coming up, that patients can be more empowered if the right tools are developed, and that they can also be empowered to take more charge of their quality of life, which ultimately will also relieve pressures on the healthcare system in terms of the finances needed to keep this healthcare system running. So this We Are platform, we see it really as something that is in between, let's say, the healthcare professionals, and by that we mean people like general practitioners, but also research institutes, policymakers, etc., and the individual citizens or the individual patients. So what does this platform do? Like I said, it gives each individual citizen, or we want to give each individual citizen a data pod where they can collect their data, their health data, mainly coming from healthcare apps like Fitbit or running apps, etc. So these data can be collected, and we also give the citizens control over these data in the sense that we want to promote data solidarity also. So to give the citizens the means to decide for which goals they want to share these data with the healthcare professionals, because as has already been said many times also, these data that are coming from these wearables, they also have, of course, enormous value for healthcare research and healthcare policy. So that's basically, so in a nutshell, the dual purpose that we have. So on the one hand, we also want, like the previous speaker, we want to put the citizen and the patient back into the center of this data ecosystem. So in the sense that we want to help them, to empower them, not only in the self-management of their quality of life through data and wearables, but also make sure that the right kinds of wearables and apps are being developed. And like I said, we want to promote data solidarity. So that is enormous amount of health data which are right now out of, or outside of the official healthcare system, that they can also be made available to the official healthcare system and to the research to deliver value. So how do we do that? Well, we conceive of the platform as existing of different layers. So of course, the first layer is the individual. And so each individual will be given, like I said, an individual data space or a data pod, or however you want to call it. And this is based on the solid architecture. So I'm not an ICT person, so also for me, no technical questions, please. But it's also it is in universal standard, so it ensures a fully interoperable standard. And it is actually also the technology that is right now being used by Atumi, which is the Flemish data infrastructure provider. So not only Atumi is not only working with health data, it's working with data in general, but we are partnering with them for health data specifically. So that's the first layer, the data storage layer, let's say the ICT infrastructure. Of course, the citizen will not interact directly with this solid code. So around that, we have built or are building different components, which is the interface for the citizen towards this individual data space or data pod. What will be in there? Of course, there will be have to be some means for identifying yourself to have access to your data space. This could be, of course, for instance, through the It's Me system that is very common in Belgium. Then there will also be a personal information manager, which will take the shape of a kind of dashboard showing which apps or wearables or organizations you have given access to your data. And there's also a consent management app, which I will talk a bit more later. Then very important, of course, for Atumi is that we are building also a catalog of the data that can be in the pod. So, of course, if as an organization you are interested in doing research, for instance, you of course have to know what kind of data are in all these pods that are on the Atumi platform. So that's the R&D catalog. And like I said, there is also, of course, the interoperability issue. So there has to be some kind of technical cookbook, like they call it, for how, as an application builder, you can get connection to the platform. But then last but not least, of course, we are well aware that decisions about sharing data can to some extent be transferred to individuals, but we cannot put all of the responsibility on their shoulders. We cannot expect that each individual citizen will be interested in becoming a full-time health data manager in the future. So that's why we also built this third layer in the data platform, which is the organizational and data governance. And so there, the idea is that before you get, as an organization, you get access to the data platform, you first have to pass an ethical screening, an ethical test. And there we are also going to set this up, that this test will be performed by a citizen panel, so by an ordinary citizen, where needed, of course, supported by experts. So this is the ethical screening, of course, the legal screening and the technical screening, organizational screening, whether you have a data protection officer in your organization, etc. This will be done by Atumi. So there will be a clear separation of tasks. So Atumi will do more the legal technical screening, and VR will do the ethical screening, which will also be about, as mentioned by one of the previous speakers, for instance, the societal value that you aim at by creating your app or your service. So that's how the organization will look like. So we are right now in the process of setting this up. First, of course, with the initial VR partners, the 4 that I mentioned. But of course, we hope that this platform will grow and that other organizations will be able to join. So we set it up as a public benefit foundation. Mainly because we also have a charter with our ethical principles, which are for a large part also based on the caring technology principles. And so this foundation is will be instituted with the purpose of guaranteeing these principles that are in the charter. And then very briefly, the structure will be, there will be a general council, which will have a representation of all the founding members. And then we will have a daily management, which will be clearly separated from the part that will do the ethical check. So we will have a coordinator for the ethical committee, and then the ethical committee itself, which will, like I said, be composed also of citizens. But there is a clear separation between, let's say, the daily management, which will, for instance, update the components that I talked about, and the ethical part, so that there will clearly not be a conflict of interest in that. And then recently we also started talks with official representatives of, let's say, the official healthcare system, like and the e-health system, like VitaLink and Mijn Gezondheid. So there we are also aiming to build connectors so that these data can be combined with data coming from wearables and apps. Okay, so that's yeah, so far a few of the apps that have already been connected to the VR platform. Of course, so far we have mainly been into the piloting phase, but this phase should be ended by September this year, and then we hope to have the foundation also ready, and that the platform can be launched for real. So this is also a recent project that started up, the Well Data project. It's an Interreg project that focuses more on how a similar system can be set up, but then for sharing data between Belgium and the Netherlands. So here are the QR codes so that you can check it out. And that's mainly what I wanted to say. So here are also the contact data. In case you have more questions after the webinar, you're also very welcome to contact us. Thank you.
Thank you very much, Erik. So with this, we finish the official part with the presentations, and we can jump right into the discussion. I'm going to welcome back all of the speakers, and we already have questions coming in the Q&A. So I will start with the one addressing all of you. It is from an anonymous attendee, so we cannot share the name. And they're asking, in your opinion, what would be the 3 top principles and values that any use of AI targeting and for the benefit of citizens should be based on, I suppose. So whoever would like to votes or classify the top 3 principles. We already had several frameworks mentioned: data solidarity, the transparent AI principles of the high-level expert group, the 8 caring technology principles in Belgium. Please, you can go, whoever would like to go.
Yeah, more than willing to start the discussion on this one. I just want to add one that kind of supersedes everything, and it's a very obvious one, is do no harm. And of course, when you say do no harm, it's clearly an obvious one in healthcare. Not that I doubt that there's people working in healthcare that want to do harm, but I just want to flip it around and say, if there's people, organizations that want to help, that they should be empowered to do so. Stefan already mentioned that the patients want to have a voice, but that are not empowered to do so. I think it's at the same level that we look, for instance, at access to data for commercial organizations. Yes, there's a commercial gain to be made. However, if they intend to do no harm and they want to help patients, who are we to judge that they shouldn't have access to certain data sets? So I like to inverse it, say do no harm is an ethical principle, of course, but also when you adhere to that you should be able to go to the next step, whatever the next step is.
Thank you, Tom. So Gauthier perhaps had his hands go up if you'd like to react.
Yes, that's a very difficult question, but I fully agree with Tom, actually. I would like to complement from the perspective of technological development. I would say that one of the key principles is transparency, because from transparency, you get freedom to act, freedom to understand what happens with the technological process. And if you are implementing transparency sufficiently, then you will create a lever for more action downstream. So I think this is very key and derives many questions on autonomy, for example, and added value of the system, etc., etc.
Thank you, Stefan.
I think for me, the critical thing is, what are the questions for which you need the data? And I think this is, we start building a house, trying to put bricks together from different sources, but we have no plan for the architecture of the house that we're trying to build. So it's sometimes a little bizarre that we're talking about the bricks and not about the house. I think it's very important to ask the right questions. What do we as patients want to have out of healthcare? And what are the data that we need to get these results? I mean, for me, this is still the primary question. How is it possible that in 2 hospitals in Belgium for colorectal cancer, you have 13 times more chances of mortality in one hospital than in the other? It's 20 times 20, factor 20 in Sweden. It's factor 14 in Germany. How is this possible? I, as a patient, should be able to ask the question, which hospital is going to treat me best with the least consequences? That is a valid question for me as a patient, using taxpayers' money to regain my health. Today, this is all obscure, and if the data don't even exist very often, but this is the data that we need. This is the information that we as patients would need to be able to get the best possible treatment. And that's the data that hospitals also need to improve themselves, get better access, get better practices, etc., etc. And AI can help in the totality of things to make sure that the right things are aggregated and better collected. But I think we have to start with the questions. What is really relevant for patients? And let's start from that.
Thank you, Stefan. Magdalena?
Yes, I find it quite difficult to choose like the single most important principle, but one that I find really relevant is to think about inclusion in data and to think about what type of data we're talking about when we refer to health data. And there's a huge problem of data discrimination and a huge data gap. And what we're seeing is that already marginalized groups within the healthcare system are a lot less represented in these large data sets at the moment. And I think it's unimaginable to us at the moment how many downstream dangerous consequences this will create, because these large data models are the basis of future healthcare decisions, be it on a genetic level or if new medication is developed, or even on public healthcare level of preparedness. And I think what we need to be doing is to be thinking a lot more about how to include marginalized groups in data set, how to encourage them to participate in a way that mitigates harm, because otherwise we're building data sets that are extremely exclusionary. And if that data then goes on to be translated into health tech, we're creating health technologies that won't be able to help everyone equally.
Thank you, Magdalena. And perhaps Erik, if you'd like to add.
Maybe to add one thing. For me very important is the meaning of autonomy and empowerment with AI systems. So right now, I think it's already very difficult for a patient, if you are confronted with a general practitioner that has much more knowledge than you, to bring in something about your own healthcare. So if that is even backed up with AI decision support tools. So it becomes, I think, very difficult to have a voice as a patient in that whole expert system that is being built up. So that's maybe a concern that I have.
Thank you. Perhaps one question from me before we continue with several other questions from the participants, because it relates to this trying to find the top principle or the top value. And as we saw, we have so many different frameworks, some of them very national, like the HCTP, some of them really EU level. Do you think, because when it comes to law, it is the law, it is mandatory, we have to follow it. With ethical frameworks, we have the freedom to perhaps choose. Do you think there is a way to make them work together, or is there a way to choose? We have, for instance, the Pluto tool, but with the HCTPs, we have a tool developed by VITO to assess the HCTP involvement and use in health development. Is there a way to prioritize between ethical frameworks? Whoever would like to go.
Maybe I can react to that since you mentioned the tool. I think a lot of it depends on the perspective from which you are using the tool. So we, in our tool, for instance, we made an entry for citizens, for patients, for technology developers, for healthcare professionals. So the perspective is important, and also the purpose for which you want to use the tool. So is it for instance, evaluating an existing app, or is it, do you want to use it as a guide for developing a new app? So I think you will not find one tool or one ethical framework to rule them all. I think it depends a lot on context and what you want to use it for.
Thank you, Erik.
Maybe if I can just jump into the discussion, and I think it's also something that is culturally bound, in the sense that ethics is not the same in every country. You have in Europe, you have European law, but you don't have European ethics. The discussion on what is the European culture, what are we trying to safeguard in terms of European values when it comes down to EU legislation, that is a really difficult question. So getting to the point where you have one framework to rule them all, I think is a bit too difficult, and maybe the search is going to take longer than the impact it will have. I think it's more important to look at, like Erik said, on what is the application level. Like for AI, okay, there's a trustworthy AI framework from Europe that kind of supersedes many other frameworks. Let's at least start from there. But in other things, it might be more closely related to the 8 caring technology principles. If you're developing another type of technology. If you're developing a medical device that has some kind of patient interface with it, maybe another framework would be valid. So I think the thought process is more important than the tools that you use.
Thank you, Tom.
And then I jump again after Tom, because I'm agreeing also actually about this logic, of going deeper and deeper into the details depending on your system characteristics or technology, intended purpose, things like this. The only thing is that there is a risk of doing ethics shopping, meaning that you are selecting actually the tool that is more convenient for you. And this should not be something included in this logic. And I'm sure Tom is not asking for that, but I just wanted to raise also this risk of selecting, the tools that will be the easier actually in your context. Then we have EU values actually, and we have EU ethical principles that is coming from our shared cultural background. But indeed, there are many national specificities to consider, and let's say even geographically in one country, when you want to address one technology to one population located in one geographical area, you can have different ethical approach than if you were addressing only persons living in big cities, for example. So it's a complex question, but interesting to address.
Thank you. Thank you, Gauthier. Magdalena?
Yeah, absolutely. And just add on to previous discussions, I think it's a careful balance that has to be stricken, that my group also explored in an article recently, is to see where is it important to also consider cultural norms and local contexts and community contexts, and where do we say, okay, while it is important to consider that, what are some human rights that should be in place in data use? And then there are larger ethical questions, such as who gets to dictate what human rights are and how they're defined. But I think with ethical principles, and especially in healthcare, there's always a very careful balance to be struck between considering community context, community needs, and how perhaps generalizable principles can also be translated into local contexts to make healthcare work there the best it can.
Thank you. And Stefan, if you'd like to add?
No, I think I agree with Magdalena. I think it's important to make sure that equality is taken into account. I think this is one of the biggest challenges that we are faced with, especially in a country like Belgium, where such a large part of the population is of non-Belgian origin. I think it brings its challenges with it, but at the same time, it's also an opportunity, because you get many more insights than you had before. People with different genetic backgrounds can also shed some light on things that work in a different way. The big challenge is to integrate them. And it's like, those people, and I think also to integrate the voice of the patient who are no longer alive is also one of the biggest challenges. Because it's easy to have data of patients who are alive, but but you also need, in order to evaluate the system, to capture the data of those who are no longer with us, because they did not survive their treatment. And the reason to ask why is absolutely critical. And I'll give you 2 examples. In cancer, many patients die of sepsis, and many patients die of undernourishment. These are data that are not typically captured. So if 10% of patients die of sepsis, cancer patients die of sepsis, right? If there's no way to capture sepsis in the system, if you have no data, you cannot prevent it and make sure that in the future it's taken away from the system. Around 10 to 20% of cancer patients die of malnutrition, which is a shocking figure. We don't have this information as a standard treatment, so as a standard data set. So we only have patients who die from cancer, and then that's provided as the cause of the death. And I think it's very important to have data that are much more subtle and much more workable in a pragmatic sense afterwards. That's also something to do with ethics. And that's why I come back, the ethic is a pragmatic question. What can we do to make sure that the patient outcomes is optimal? And that's the basis for the entire population of patients with a specific disease. And that's why I also think that ethics is something that has to be determined by disease almost, because that's the level in which you want to work. That's the level in which healthcare systems should be set up. That's where choices are made. That's where treatment plans are developed. So you have to work from the bottom up rather than top down, the pragmatic approach.
Thank you. I go back to the Q&A and questions from the audience, and we have some specific questions to some of you. First, from Professor Grit Vergendeman to Magdalena. So Grit is saying, the idea to define and calculate public value is an interesting idea. Thank you for sharing the Pluto tool with us. In the European Health Data Space Regulation, it seems a similar concept was used in reference to secondary use, social benefits. Have you looked into that concept, and are the concepts aligned?
Yes, we've looked into it, and I think it has a lot of overlaps, as many of these ethical frameworks do. And I think that's also the beauty of them. It often seems like there's many different approaches to regulating digital spaces on an ethical level. But at the same time, I think it's also very interesting to see how they overlap, how they feed into each other. And I think there's a lot to be learned when many different approaches try to get at some of the same core questions, right? Because that really tells you that you have something there that's worth looking at. Thank you for the question. I appreciate it.
Thank you. And still on the topic of the Health Data Space Regulation, very much a hot topic at the moment since it was adopted this year. We have a question to Gauthier from Tasha Petrochnik. Wonderful presentation, thanks, she says. I was wondering about the role of the health data access bodies, specifically their transparency and accountability obligations vis-a-vis the natural persons under the health data space. How to ensure that this role will be fulfilled meaningfully and not just as a formality or an afterthought. Gauthier mentioned that the work is ongoing on dynamic consents and transparency mechanisms, which is to be welcomed. I would be curious to hear more about these efforts and the extent to which this could be implemented in a coordinated way across the EU.
Thank you very much for the question and the compliments. I think actually this is part of the main challenge we will have in the coming years, to design systems that will ensure transparency for the people and all the people with the heterogeneity of the population. So works are ongoing on transparency portals that are spaces where actually you can have an overview of all the data that have been collected about you and that are used or reused for scientific research and for which scientific research or program in order for you to be able to refuse participation. This is a broad approach that is actually under work, but there is not yet a concrete application of this, at least as far as I know, in my country. But works are ongoing, and the idea is to enjoy the new technologies, also to facilitate the effective implementation of individual rights. But there are many issues. How do you do for elderly, for example, or for young people? Yeah, it's a challenge. Stay tuned, but yeah, we'll see. At least the obligation is there, so we'll be able to act if something is wrong.
Thank you, Gauthier. We have another question to everyone from Jean-Christophe Chiem. What could be the best reward policy without implying infringements, bias, collusion in the way we ask the involvement of patients? Anyone that would like to react?
Teodora, would you mind repeating the question?
Yeah. What could be the best reward policy without implying infringements, bias, or collusion in the way we ask the involvement of patients?
Yeah, that's a great question. I don't have a complete answer, but maybe I can kick it off. So I think without providing any rewards, or before even we start thinking about rewards, what we should be thinking about is outreach, right? Like at the moment, often, if it comes to patient participation, for example, the message is spread that there's a study taking place over social media, right? And by definition, that excludes a large number of people that don't use social media or that are not as digitally, apt. So I think in the future, to create good data for health technologies, we really have to think about what we're doing to get in contact with the right groups of patients. How easy do we make it for them to participate? Because at the moment, many studies require patients to come into hospitals, for example, and there's newer methods of thinking about decentralized trials and so on. So I think we really need to start thinking about how easy we make it for people to participate and reduce barriers before we even start thinking about what reward policies could be. And at the moment, I feel like we're only reaching very specific groups of patients, and others, due to care duties or due to living far away, can't really be included in a lot of user trials, for example.
If I can jump into that. Sorry, Stefan.
No, go ahead, Tom.
Just a couple of points, because I'm interested to hear Stefan's point of view as well. But I think it depends on what the input is and what the potential output could be in terms of reimbursement or rewards for the patient. I think a fair principle would be whatever the effort is that you need to put in would be equal in terms of reward. Like Stefan is saying, if you're asked to participate and move to a location where you need to spend 2 hours in traffic and drive for 100 kilometers without any reimbursement of mileage, I don't find that fair. If a patient is only not even actively donating data, do we need to reward them for that? That is a totally different discussion. So I think it's really difficult to give one straight answer on a reward policy in terms of any health technology. It's going to be very case-based. But I'm absolutely convinced that there should be a reward. The example that Stefan gave is indeed not very correct. Just like you would hire an external advisor to advise your technology company or organization, a patient is just an advisor as well. So it should be equal. That's my point.
And Stefan, yeah, you're muted.
Yeah, I wanted to say that for patients, you have different degrees and different levels in which, of course, this becomes applicable. I think many patients are looking out for information. We have to know, I mean, from all the studies that we've done around, patients feel that they receive around 50% of the information they need from the medical staff to be able to live with their disease. So there's a huge information need among patients to make sure that they understand how to organize their lives practically around their disease. This type of information seeking by itself is already a reward. So if you manage to have technology, wearables, but other devices connected to forums where people can find information, but also share information, I think that's the winning formula. And system like that already exist in some countries to make it work. And I think this is one of the critical things. People get their interest to participate in these things, even if they have low literacy, if the easy access is there, and if they see a valid interest to help live through the day and find some solutions for the problems they are confronted with. So I think this is one critical thing. At the level of patient organizations, I think we should be funded for the work that we do. Publicly funded, but also commercially funded. I mean, if we help design a patient pathway for a disease in a hospital, the time should be remunerated. So, I mean, we asked, for instance, with our patient expert center, €100 per hour for the time investment. That's very low compared to consultants and lawyers. But I think it's okay for patients, and that's what we ask for our patient experts. So if we set up programs in collaboration with hospitals or government agencies, that's the kind of money we're talking about, and that can be projects from 5 to 30, 50,000 euro, depending on the time investment, on the expected value to be generated, etc. And then we're also trying to set up patient databases so that patients can show and share their profiles, so that we can easily help to find patients with very specific requirements and diseases to participate either in surveys or workshops, but also in clinical trials. And so we will have sufficiently detailed patient profiles to be able to do that in terms of comorbidities, demographic data, socioeconomic data, education levels, etc., so that we can have representative data groups for patient panels, or whatever it is that is required to have representative voice. And of course, they should be remunerated as well.
Thank you, Stefan. We have an interesting comments in the chats, a little bit provocative as well, that I would like also to bring up and see perhaps your views and suggestions how we can tackle it. It is from Tine van den Sande, that she has also been quite instrumental in the 8 caring technology principles. She's sharing, thank you for the contributions on citizen involvement in health tech. I must note that the language being used still feels quite top-down. Terms like citizens, acceptance, citizen empowerment and education suggest still a one-directional approach. If we truly want to engage citizens, we need to move beyond the jargon and really understand citizens' needs and make sure we serve the public interests. So I'm curious, what do you think about that? How can we move indeed beyond the way that we speak in our bubble, perhaps?
Yes, indeed. I think I agree partially, at least, because like even the term citizen involvement implies an in-group and an out-group, and like you're inviting people to come join you, but it's your project at the end of the day, right? So I think in the future, and I do see trends moving in that direction, we very much have to push for a stronger idea of co-creation. And in the research realm, but I would imagine it's similar in companies, that would even imply asking citizens and especially patients what solutions they actually want, what types of questions they think we should be working on, right? So in terms of me as a researcher, and many of you, this could, for example, imply that you don't just ask patients to come contribute once you've devised your research questions and methods and so on, but you actually have an open dialogue about what type of research public resources should even be invested in, right? And then we're moving slowly but surely towards a more equitable approach of agenda setting in healthcare and health data use.
Thank you. Maybe Stefan, if you'd like to also add.
Yeah, I mean, I fully agree. I think this is the uphill battle that we have to fight. It requires an entire culture and mind shift. We are in the system. It's about us, And I'm sometimes shocked. I was at a meeting recently with the people from the Diagnostic Reimbursement Committee in Belgium, and they said, well, we can only do this taking into account the expectations and the needs of patients. And so I asked him, but who decides about these needs and expectations of the patients? He said, we do. And I said, who is we? Well, it's the doctors and the insurance in the payment committee. And I said, but how do you know then what the needs and the expectations are of patients? Have you done surveys? Have you consulted them? What did you do? No, we know that, he said, And I think this is the battle. This is so ingrained in people's minds that they've highly educated and have a lot of appreciation for that. But you don't know what patients need or patients want. Ask the patient and then you know. And so this integration of the voice would really be a standard practice at every level of decision making. It's not something nice to put. It's not a cherry on the cake. It's the essence. It's the absolute essence of it.
Yeah, Stefan, I agree. And I would even say we have to go a step further, like asking patients is very often done in a way where we tell them, do you want A or do you want B, based on pre-assumptions by
Exactly.
that you mentioned, like healthcare workers or insurances. But I think we would need new research methods of really opening up the questions and asking them in a world with a bunch of available solutions. If you open up, what are some options for you? What could that even look like, right? If we already
that's what we typically do before surveys are conducted, is to have a focus group session with patients with different backgrounds to really understand the issues and the concerns, so that we can have tailor-made questions adapted to their context. I think that's absolutely the minimum. Yeah.
If I can just add one thing to that. I like to use the quote from Uncle Ben from Spider-Man: with great power comes great responsibility. I'm absolutely agreeing with Tina's point that it should not be dumbing down on the patient and be very, from a paternalistic point of view, talking about patient without the patient involvement. But if we really do patient empowerment, if we give the power to the patient, there's also a responsibility at the patient side to be willing to continuously learn about the topic, to investigate time, to invest time and energy, to investigate further on the topic, and to take a really conscious decision about his or her disease pattern or whatever therapy that needs to be decided upon. It should not be a one or the other. That's what I'm trying to say. It's about really, there's no party asking and the other one pushing. It should be a combined effort. Also, when I talk about acceptable AI, it's not the tech community that is pushing AI in healthcare. It should be a question, and it should start with desirability, and that's the question from the care professional and from the patient, and then the tech community can see what they can do to answer that question. So I understand that in the system and systematically it has the image of dumbing down on the patient. But like it was already said, Magdalena already said, we need new ways of research as well, not to only involve people, but really make people part as sort of a natural flow of research. Of course, patients are involved. And then the term citizen or patient in the pre-call, we also had a discussion on that. What is a citizen? What is a patient? At what point does a citizen become a patient? Is patient subset of citizens? Is every citizen at one point a patient? Semantics, of course, you need to find some term at a certain point, but I totally understand the remark.
Thank you. Perhaps a question from me before I go back to the last questions from the audience. When it comes to the responsibility and giving power to the citizens, to the patients, I've seen also in literature sometimes people refusing to be involved as a form of protests against AI developments and so on. What do you think about this refusal? How can we discuss it? How can we make sense of it? How can we best respect it as well in the development as well?
I think, like in everything, you have to demonstrate the value of what it is that you're doing. And if people see the benefit of it, of course, they will go for it. I mean, EPF, European Patient Forum, did a survey a number of years ago on the willingness of patients to share their data. So they did this across the member states. And so 93% of patients were willing to share their data if it helps the research for the specific community they represent. And only 3% were against it. So I think this showed that there's a high willingness to actively share and participate. So this kind of data solidarity is something that exists in the patient community. Because we all know what it means to live with a disease. We know the struggles that we go through every day, what it means for the family, what it means for the quality of life and your income, revenue, life perspectives and things like that. So I think this is really critical. And patients are willing to help others because they want to avoid them to go through the same ordeal. So I think this willingness exists, and I've seen fantastic things in AI in terms of diagnostics, things that individual doctors or radiologists can impossibly see. AI is able to pick it out and make a right diagnosis. I mean, same thing in treatment or even in surgery. Fantastic things are being done, but you have to show to patients what it actually means. I mean, many of the things that we are today experiencing were sometimes questioned in history. Taking blood samples, for instance, at a certain moment in time, people questioned it. What's the point of that? Are people going to trust that? Why would you take blood from them? Today, it's so standard that nobody questions it anymore. So I think with AI, it will be the same, but you just have to explain it and make sure it becomes the standard practice. Obviously, we have to protect the patients, of course, in the right environment. I think it should be no issue.
Yeah, just like a patient can refuse therapy, I think a patient can refuse to donate data. However, there's limitations. Anything that has to do with public health, for instance, just like you cannot ask the tax authorities to forget about you. That's an illusion. But within those or those exceptions kept aside, I think there's always the freedom of the patient. However, that means that it needs to be an informed decision and not a decision based on FUD, fear, uncertainty, and doubt. It should not be, oh, I don't trust my data to be used because the industry, whoever the industry is, will do really awful things with that. That is based on fear. But if you explain to a patient what secondary use is, if you explain what the purpose is of research, how we get to new ways of treatment, how we get to new therapies, how we get to new medications, then donating your data becomes extremely obvious. And of course, you do that at a certain point. It's usually easier to compare it with asking a patient, yeah, with your insights, you could potentially be able to help your kids or your grandkids. Would you then donate your data? Yes, of course. Well, it's now somebody else's grandchildren that you're donating data for, not per se your own. But it takes time and it takes education to explain that. And that's also an assignment for governments, for organizations, healthcare providers to take the time to explain that and not just give a piece of paper and please sign off at the bottom and otherwise we can't treat you.
Yes, absolutely. And I think something crucial to consider is also historical and current marginalizations, right? If we're asking people to donate their data, this ask does not apply to everyone equally, right? Like depending on our privileges, it might be a lot easier to say yes to donating data. But if you're part of a group that has been historically massively disadvantaged or even abused by the medical system at large, it's not the same ask to donate data, right? So it is, I agree with you, Tom, it is about education, it is about informed consent. But I think we also have to really think about which groups are currently being left behind in the medical system at large. This is happening every day. And if we start working against inequity that's in place, then the chances of people agreeing now or in the future to donate data will go up massively. But if they're experiencing their data being used against their will and so on, or have a history of bad experiences in the medical system, then of course agreeing to data donation is a very, very different baseline situation. So I feel like a lot of people not wanting to donate their data now is because of things that we as a system have messed up in the past. And that of course means that we have to very carefully consider what we're doing now if we want people in 15, 20, 30 years to donate data.
Yeah, if I can add to that, so we also did a survey in the context of our VR platform, and it confirms that people are very willing to share their data, but that they also so maybe this phenomenon that you described, that people would not like to share any data, comes from a feeling of having no information whatsoever of what's happening with the data right now. So it's not. It's a matter, I think, of like Gauthier said, maybe these interfaces, these transparency platforms, that would really already help, I think, to dispel a lot of the distrust that exists, because people just don't know what happens with the data. So even, and then you of course have the spectacular cases where things go wrong. Yeah. They get in the media. So that's maybe one instance where it goes wrong, but it captures all the attention. So.
And you also have to understand that there are some vested interests who do not want transparency of data and data sharing, because it would allow for benchmarking treatments, doctors, hospitals against each other. And I think there's not everybody is in favor of transparency except for their own performances, right? I think that's also one of the things that we are encountering.
Yeah. And I think to add to this discussion that even for those that are willingful for sharing their data, we should also envisage, several means for them to manage or to not manage their data, because some of them are willing to share, but they don't want actually to take, active participation into the management of their data. So it should also be considered. We should also consider, means for protecting them, and the law is there for that. But we have also other mechanisms like ethics committees, for example, that are taking care of their best interest or the societal value of activities taking place on their data. So I think it's a granularity also to envisage to embrace the whole variety of point of view.
Thank you, Gauthier. We're almost at the end of closing today's session. I have one last question to you from the Naya Fabčić-Bovce, which I think it's interesting to address in the last 1 minute. It is about whether, in your experience of advocacy, how likely are decision makers to take patient perspectives seriously in actual legislation, so when we're preparing all the new regulations and directives. For instance, are patient concerns only listened to, or do they actually translate into the new laws? Maybe Gauthier or Stefan, if you have some practical experience observing that.
So my practical experience, the door is always open, actually, to hear, from patient organizations and other community-driven organizations. But then, indeed, at the end of the day, everything is political, and so you have economical issues, of course, that are very, very important for building policies that will also help for the economic growth, and so everything is a trade-off, between meeting the interest of the one and meeting the interest of the other. So the door is open. This is for sure. The processes are efficient, I would say, in terms of implementation. Then you are always losing control at a certain point where it is coming in front of political institutions. So this is my experience, but at least we can contribute and make it visible and eventually build on that when our solutions have not been followed or integrated properly. So it's part of the democratic process, actually. Some will win, some will be disappointed.
I agree. I mean, I have the same experience. I mean, working with the European Beating Cancer Plan very intensely, we reviewed several drafts of it, and we as patient organizations had ambitions that were a little bit higher than the end document of the Beating Cancer Plan. But then they actually listened to countries that were not willing to make such an investment in healthcare. And so the outcome, of course, was political. It had to accommodate, the average in Europe. And so we thought, we're going to improve the system. That actually did not take place in a significant way. So the goals could have been a little bit more aspirational than they are today.
If I can just add to that point,
Yeah,
and maybe
course.
generalize a little bit, patient involvement or citizen involvement or whatever should be available at any level, at legislators level. Yes, there's of course always a trade-off to be made at the board of healthcare organizations, in committees at government level on reimbursement, but it's a perspective. It's not the perspective.
Mm-hmm.
Yes, it's an important perspective, but like Gauthier said, at a certain point, there needs to be a political consensus trading off economic decisions versus patient perspective versus other perspectives from healthcare providers, from governments who needs to fund it, from taxpayers, what have you. All these things are dimensions, are inputs, and all of them are important. But at a certain point, there needs to be a decision to be made. Just like if you are, as a patient in a board of a hospital, you can raise your voice about the importance of a patient, but you cannot control, for instance, the financial agenda of a hospital. You can give your perspective, and that's then taken into consideration. But you should have the opportunity to give your perspective, and that is now underrepresented.
Correct.
Thank you. Maybe Magdalena or Erik, if you'd like to add any last concluding words on this or general reflection.
I don't have any last reflections, but I just wanted to say thank you, Teodora, for moderating super well, and thank you all for the really interesting discussions.
Thank you very much to all of you for your time and willingness to participate, for all the shared insights. Definitely, it's a dialogue that we need to continue in the future to expand further. Many thanks also to everyone in the audience for the active participation and being so interested to ask questions and to follow up with you. We'll be in touch in the future with the recording of today's webinar, and definitely don't hesitate to get in touch for any comments, to continue the discussion, to find ways to do something further together as well. Thank you, everyone, and I wish you a great Monday evening.
Same to you.
Thank you very much.
Thank you.
Thanks
Bye-bye.
for organizing.
Bye-bye.
Bye-bye.